Hello, everyone. This is Dr. Carrie Bedient of Fertility Center of Las Vegas, joined for another episode of Fertility Docs Uncensored with my two just absolutely fantabulous co-hosts, Dr. Abby Eblen from Nashville Fertility Center
Hey, everybody.
and Dr. Susan Hudson from Texas Fertility Center.
Hello.
How are you girls doing? Are you excited about Thanksgiving and all of the food?
Cannot wait.
Getting
Cannot
there.
wait. Love to make desserts. That's my favorite thing of Thanksgiving.
Yeah. So who handles the turkey for you guys' houses?
Publix or Corky's? I'm not kidding. And it's really good too. I'm not kidding.
So historically at our house, my cousin and I have been doing the cooking for the last number of years. And so we pretty much handle everything, but I'm pretty sure my brother-in-law is going to come and he comes with a turkey fryer. So
Awesome.
last year we did one smoked turkey and we did one fried turkey, and it was really fun having both of them. So it was very, very different, but yummy all around.
That sounds delicious and kind of dangerous too. Like I've always been afraid to fry a turkey because I don't want to set the house on fire or explode anything.
I mean, I completely agree. I completely agree. He has a whole setup, and you have a hose running the whole time so that because it splatters and stuff like this. I'm the person who doesn't fry anything in my kitchen. Because
Do you do that in the
I don't like
house?
the little poppy things. They hurt.
No. Do
No,
you
they
do that
do.
do you do that in the house?
The frying the turkey? Heck no. It's out on the back.
Oh,
It's on our
Okay.
driveway.
Okay. So Susan, I have to just bring this up because I just had a flashback to something you told me when we were at the meeting, at the ASRM meeting back in October about frying stuff. Do
Oh,
you remember
yes.
that?
Oh, this is so funny. So one time we were at Sunday school, my husband and I, and we were in a marrieds group, and we were talking about advice.
Young marrieds group.
and,
I know where this is going.
that people have been given. And this was not advice given to us, but this was somebody else's. But it was so memorable. Like we still joke about it. And the words of advice were, "Don't fry bacon naked."
So when you talked about all the little poppy things, I'm like, who just told me about frying bacon naked? And I'm like, Susan.
And that prompted a long discussion about the difference between naked, N-A-K-E-D,
and
and naked,
Naked.
naked and naked. Yeah.
N-E-K-K-I-D. And I feel like if you're frying bacon naked, you're actually frying bacon naked.
Agreed.
That's fabulous.
Funny.
We've got somewhere around 20 to 30 people coming, and I'm usually in charge of all of
Wow.
the cooking and organizational stuff. So, but I really want to fry a turkey at some point. I'm just not willing to take that on unless somebody else is dedicated to it while I'm handling everything else.
It honestly takes its own person.
Very stressful.
But
yeah.
But if somebody in your cooking party wants to talk to my brother-in-law, I will definitely hook you up because he does an amazing job. It's all like even certain parts of the bird you don't put in at the same time. Like I think the wings, you put them in later because if you cook them at the same time, they'd be like crispy
Overcooked.
critters.
Yeah.
And so there's an art to the frying of a turkey.
Okay.
Not an art I wish to accomplish, but I'm happy to have it happen on my driveway.
So you guys laughed when I said that I use Publix or Corky's, which I typically do, but this year I'm not doing that. This year I'm going to be flying to Syracuse, New York on Thanksgiving Day because that's the only time we could get a plane ticket to get there. I have a son that's about to graduate, and he's going to be announced at the football game on that weekend. It's their last home football game.
Oh,
So the whole family will be gathering in Syracuse, New York. So I'm just really hoping that I'll be able to make it back by Monday to work because I'm a little afraid with the crowds of people that are flying and, flying in Syracuse and, November's not a
November.
great time to fly.
Yeah.
So there may be a little snow or something. So hopefully we'll be able to get out and
There will
make it
probably
back
be
by
some
Monday
snow.
for work.
Yeah. Yeesh. Okay, Susan, what kind of questions do we have?
Okay. I've had multiple different types of pregnancy loss and would love your thoughts on what my best next step is to have an alive, healthy baby. First pregnancy conceived at 36 in 2 months, lost my baby at 20 weeks. Genetically normal, no apparent cause. Second pregnancy conceived at 37 in 6 months, lost at 7 weeks. This was due to a genetic abnormality. Found I have a paracentric chromosome inversion. Other recurrent pregnancy loss tests came out normal. Went to a fertility specialist and conceived third pregnancy at 38 in 5 months, second IUI. This was a complete molar pregnancy, so now I have to wait at least 6 months before trying again. What should I look into now once I can try again? FSH 22, AMH 0.268, AFC 7 to 9, TSH 1.8. Thank you for your perspective and podcast.
Ooh. The
FSH
first place,
22.
FSH at 22, which is high.
Wow.
The first place my mind goes to in all of this is IVF with PGTA done with a SNP array, not NGS, because you need that really detailed look. And so
SNP array would be,
so SNP array it's a different platform for running the PGS testing. So regardless of what PGT testing you're doing, you want to know the total number of chromosomes. NGS versus SNP array is the way that you get there. So most people at this point do NGS because the technology has been around a little bit longer, but SNP arrays are becoming much, much more common now. And so that's like for the three of us, SNP array is what we use whenever we have the opportunity, because instead of looking at like, 20,000 points, which is what you do on most NGS, you're looking at 800,000, which is what you're looking at a SNP array. So it's just a lot more information. So you can really get to a paracentric chromosomal inversion and figure out which one's important, which one's not. Now, not all of those inversions are clinically important. Some of them are just there and they don't necessarily relate to everything. So I don't know that I would totally blame it on that, but you and your doc know better because you've seen the reports and they will give you more information with that. But
that'll also help prevent a molar pregnancy
that will also help prevent a molar pregnancy.
Yeah.
And I would do not just PGTA with SNP array, but I would also do PGTA plus, because that's going to look at the origin of the chromosomes. And molar pregnancies are so challenging because you end up with a faulty origin. Instead of coming from half from one parent, the other half from the other parent, you get all from a single parent. And that's part of what causes the problem. So, at a glance, I think IVF with SNP array doing your PGT, and I would use PGTA plus.
Well, and just leading up to it, I think it wouldn't hurt for them to both have a karyotype if they've not done that already, just to see what their chromosomal makeup is with a microarray to really look at.
Well, she has hers.
Oh, she did have hers done? Okay. Yeah. And maybe his done as well, just for the sake of completeness. Now, with the FSH of 22 and her AMH, what did she say that was?
0.268.
0.2. So my really big concern, and I don't know about Carrie or Susan's practice, but I would say probably somewhere around 30% of women don't stimulate well enough to even make it to egg retrieval with an AMH like that. I mean, nothing ventured, nothing gained, but I'm a little bit worried that you may not stimulate well enough to make it to egg retrieval. I mean, your body just may not respond well, even though you've been pregnant in the past. And, at some point, and maybe not at this point, but you might want to at least start to think a little bit about maybe using a donated egg in order to get you pregnant. And that's not for everybody, but that's something that you might want to start to consider.
Agreed.
Yeah. All right.
Okay. One more?
Let's do it.
All right. Hello. I love your podcast. Thank you so much. It's been so informative and helpful. My question is, can having a history of a LEEP to remove cervical intraepithelial neoplasia grade 2 affect fertility and the ability of sperm to make it through your cervix? It's a good question. We get this all the time. We get this all the time in clinic.
Yeah. Go for it, Susan.
I would say if it was just a LEEP, it probably has really very, very little effect on your fertility outcomes. If you have high grade dysplasia and you end up needing a cone, sometimes that may have an effect, but even with cones done nowadays, I don't think we have a whole lot of issues. And if you're doing inseminations where we're bypassing the cervix, where we're really not worried about cervical mucus and things like that, I really wouldn't be too concerned.
The other thing that I would think about is particularly if you were going through any kind of fertility testing at all, a couple of those tests by nature pass catheters into the cervix and need to put fluid in for a saline ultrasound or an HSG or what have you. And so if they can get that catheter in, then there's not scar tissue there that's problematic, because those catheters are plenty big, especially when you compare to an IUI catheter, and especially when you compare to the size of a sperm, which is itty bitty teeny tiny. And so if you're going through any fertility testing, that information will be very clearly picked up. If you're not going through fertility testing and you see your gynecologist, usually they can find that out pretty quickly with just passing an os finder or a dilator through, just to see what the passageway is like. Is it super scarred down or is it open?
Agreed.
One other thing to think about, maybe not for this listener, but for somebody else that may be listening, if you've had more than 2 procedures like that on your cervix, so say the first time around, they didn't get all the dysplasia, they had to go back in again. The more procedures that you've had, the more we worry a little bit that the cervix won't be quite as strong, because if more of the tissue has been taken away, it can make the cervix weaker. And so, make sure your doctor's aware of that, because ultimately the good news is we can look with ultrasound and measure how thick your cervix is. And if there's any indication that your cervix is starting to weaken when you do get pregnant, it starts to thin out, they can actually put a stitch in there that can kind of reinforce the cervix. And it really works quite well, as long as you know that you need to do it, and as long as you do it at the right time before the cervix is really dilated very much.
Good stuff.
Absolutely. All right. So today our topic is going to be looking at one of the big uterine factors that can really impact someone's ability to get pregnant on their own. And so this is Asherman syndrome. So Susan, what is Asherman syndrome?
So Asherman syndrome is quite simply where you have scarring within the lining of the uterus. So part of the endometrium, the part of the uterus that builds up every month and you shed with your period, gets replaced with fibrous tissue that isn't healthy endometrium.
Okay. And what are some of the other words or phrases that we use when we're talking about Asherman syndrome? So it's not always flat out called Asherman's. So the things that I'm thinking of are more
Adhesions,
adhesions, scarring, synechia.
Yeah.
That's why it's such a funny word.
Yeah. And sometimes people think of, and sometimes it can be scarring where like that the uterus is so scarred that it's stuck together, like completely obliterated or partially obliterated. Sometimes when we go in and look at it, sometimes it could look like strings of tissue. And Susan did a really good job of pointing out that a lot of Asherman's really is, when you think of scarring or scar tissue, you think of things stuck together. But it's almost like I use an analogy: if you burned your skin with your curling iron or something really severely, you still have skin there, but it's just not the same kind of tissue. It's not stretchy like your normal tissue. It's just fibrous and hard. And a lot of times we see patients with Asherman's, that's the big problem. Their normal tissue is replaced by just scar tissue, essentially, fibrous tissue.
So who are we worried about getting Asherman syndrome? Like if a patient walks into the clinic and tells us a story, what parts of her story do send off those warning signals?
A lot of times if she's had regular menstrual cycles and then some event happened and then now she's never had a period since then, those are kind of the things that kind of trip your memory. A lot of times it's after somebody's had a full-term pregnancy that we hear about it. So they've had a full-term pregnancy. Maybe the placenta didn't come out well. Maybe they had to have a DNC, a surgery to scrape out the placenta at the end. And so what happens is, in that type of environment, unfortunately, that's a perfect storm for Asherman's, because if you have low estrogen because you've just had a baby and your estrogen level drops down low, and maybe you breastfeed and it keeps your estrogen pretty low, on top of that, you've had an insult to your endometrium. Somebody scraped your endometrium. It just doesn't heal back very well, because estrogen is really healing. And if your estrogen level is low for a long period of time, it just prevents that good normal tissue from coming back. So that's a classic time that we think when somebody gives us that story, it's like, aha, I think I know what they have. There's also other things that can cause it as well.
So the times that I'm often concerned, especially at the postpartum DNC, anytime somebody has had their uterus instrumented. And so what that means is having a procedure where we had to remove something within your uterus. So whether it was a DNC, DNC stands for dilation curettage. DNC is essentially what we call blind procedure. So we're doing it by touch, where we can tell when we're at the right level of removing whatever's inside the uterus. So sometimes people have these because they've had miscarriages. Sometimes it's because they have retained products of conception, like after a delivery. Sometimes a DNC happens after you've been diagnosed with having abnormal cells within the lining of the uterus, so precancerous or maybe even cancerous cells in the uterus, because we tend to be pretty aggressive. Sometimes people have had hysteroscopies, so procedures where we put the little telescope inside the uterus and maybe had to have aggressive removal of something that was within the uterus. Those are all kind of things that we'd be concerned about. Certain health conditions also make us concerned, like tuberculosis can cause some of the worst Ashermans I've ever seen. It's pretty rare for us to see that, but it can be very substantial, especially if you live in an area that TB is endemic.
Mm-hmm.
Mm-hmm. And really any infection, particularly if it's happening at the time of uterine instrumentation. So we see this if someone had not only retained products when they delivered or had a miscarriage, but they got infected as well. Mm-hmm. And so it doesn't have to be any big, bad, and ugly kind of infection. It can just be normal vaginal bacteria that creeps up further than where it should be. But when the uterus is actively trying to heal like that and there's an infection, it's more prone to make the scar tissue. So let's talk just a touch about the physiology, because women lose their linings and they shed it completely every month. So what's the big deal if we're scraping it instead of shedding it? Why does that make any kind of difference?
Well, if you scrape it aggressively, like Susan was saying, or if you have to cut in, like if there's a big fibroid and you have to cut in and you damage some of the endometrium, you know, that there's an area of your endometrium that replenishes itself. And so your endometrial lining will grow over your, cycle, and then part of it will slough off, but there's still a little layer of those good cells left that regrow each time. And so with Asherman syndrome, it's as if, once those cells are scraped away, they can't come back. I mean, you can't replace those cells very easily. And ultimately it results in scar if you just don't have enough of the normal endometrial tissue to replenish itself each month.
Yeah. And what most people don't realize when you hear discussions about stem cells, the uterus has a pretty good supply of stem cells. And so they're sitting in that basal layer, and there's the functional layer on top of it that comes and goes each month. But if you damage those stem cells, it's just done. So, okay. When you have somebody who comes in and they're talking about, oh yeah, I had XYZ procedure or XYZ infection or what have you, or they're talking about, yeah, everything was great with my periods and then it wasn't.
I want to interrupt. There's another big one that we don't see that often in our clinic, but as you started talking, people who have had endometrial ablations, so they have intentionally
iatrogenic,
heat treatment to their uterus so that they have less bleeding or things like this. Those are the quintessential people who are going to have Asherman. So we'll mention some of these people in a few minutes after Carrie keeps on talking.
But unlike the other patients, those patients are not surprised that they don't have periods anymore. They know why they're not having periods anymore.
Yes, and it's intentional Ashermans.
Yes,
the whole point of the procedure is to do that. Good point.
But unfortunately, sometimes people change their minds.
That's true.
Yeah. Okay, so if you have somebody who comes in with any type of history like this, what kind of testing do you want to do? How do you get the information?
My preference is to do a saline sonogram while they're there in the office to really look and see how extensive the Asherman's is, because it can be anything from just a few little strings of scar tissue to like where the cavity is completely obliterated. And before you can really start trying to work on trying to help the endometrial tissues, whatever cells are there left to grow back, you sort of have to know kind of what the scope of the problem is. And so saline sonograms can be really helpful. And eventually I always will go in with a hysteroscope as well, but I just kind of want to know what I'm getting myself into, if I need an ultrasonographer there when I'm doing the procedure, just how tough it's really going to be, basically.
I think it's also helpful to see, doing a vaginal ultrasound mid-cycle before somebody ovulates to be able to see if using their own estrogen, ovulation, all that kind of good stuff, are they able to grow a lining that has the correct visual appearance on ultrasound? Some of these people are going to be able to do that to some degree. And we can look at that. We're looking for that trilaminar stripe, so 3 lines. And we like to ideally see something of, 7, 8 millimeters of.
But with
of
Asherman's, you
thickness.
won't see 7 or 8 millimeters.
But you're not. But some of it depends on the degree of the Asherman. Some people can have Ashermans and have just a small amount that's affected, and then you're going to have other people. We think of Ashermans. Oh my goodness, the obliterated cavity, and so that's going to have a big impact as well as to what do we expect to see on that hysteroscopy, and what are potentially the reproductive options. How hard are we going to have to fight that lining, and is that fight even worth it? Sometimes we have to think about using things like a gestational carrier in severe cases.
Well, at one point when you said that, Susan, made me think. I had a patient probably about 1.5 years ago that had the story where she had a baby, never had a period after having the baby. And I did look at her with ultrasound. And interestingly enough, she had a small segment at the top of her uterine cavity that was beautiful and thick and tri-layer. But when I tried to dilate her, I couldn't get through her cervical canal. So she did, and it turned out she actually did quite well, because really the biggest amount of scarring that she had was right around her cervical area. And so I did ultimately operate on her and put a catheter in to try and keep that tract open. But she actually did pretty well, because she did have a lot of good tissue at the top of her uterus, but just not a lot around her cervix.
That's the area most pregnancies implant, is at the top of the uterus. So if you've got a place that's working well, that's where you want it working well.
Yeah.
Yeah. Sometimes you can also pick it up on an HSG, because a lot of regular OBGYNs, if there's fertility issues, that's one of the first default things that everybody orders. So sometimes they'll have a lot of difficulty getting the catheter in, or when they put the fluid in. The HSG is never a particularly pleasant test, but for these patients, it's particularly uncomfortable because there's just nowhere for that fluid to go. And you see it in the photos and the report from the HSG, because instead of the uterine cavity expanding the way it should, it doesn't go anywhere. Like there's nowhere for it to go, or you see a spider webby kind of appearance where there's lots of strings of scar tissue going back and forth. So, okay. So you've done your saline ultrasound, you've done your HSG, you know that your mid-cycle ultrasound, it doesn't show much of a thick lining at all. What do?
You go to hysteroscopy. So hysteroscopy is an outpatient procedure, in and out the same day, usually back to normal activities the following day. You generally go to sleep. If we're concerned about Asherman's, this is not something I would recommend for an in-office hysteroscopy. This is where you need to,
not at all.
You need to be taking a good nap. And we put a little telescope instrument inside the uterus that's about the diameter of a pen or pencil. And we can directly see what's going on inside the uterus. And then we're able to utilize different tools. We have little graspers, we have little scissors, we have little shaving devices to help try to restore the lining of the uterus to as much of a normal shape and architecture as we possibly can.
And a lot of times these are done, and this will be the, basically what your doctor wants to do. But generally when I go in for Smith-Asherman syndrome, I always take my ultrasonographer with me, because sometimes it can be it's almost like somebody's put super glue in your cavity and everything is just stuck together. And if you can't really find where the cavity stops and the fluid pocket begins, sometimes you need some help with somebody kind of encouraging you, like, yeah, it's okay to go a little further on the right and cut a little more tissue there. And so, like Susan said, the goal is to ultimately try and get as much of a normal architecture as you can get. But I always tell my patients with Asherman's, it may be a couple of surgeries before we do that. The first surgery, in my opinion, is usually the hardest. But then once you give them some medicines, which we'll talk about in a minute, to kind of help the endometrium grow, then if you go back for a second surgery, a lot of times it becomes a little more obvious, and you kind of know what you need to work on and what little area you need to work on to open up. But a lot of times the first surgery is pretty tough as a general rule if you have a lot of scar tissue.
One thing I'd like to mention when we're talking about hysteroscopy, and people are probably listening, why would I need to do more than one surgery? when we're doing the surgery, we're putting fluid inside the uterus and we're monitoring how much fluid comes out of the body. And granted, the fluid we use, most commonly saline, so essentially fancy salt water, we can use a good amount of that, but there are certain points that we have to stop the procedure, whether we're done or not, for your safety. So if we get to that fluid deficit or the amount of fluid that we know has gone in and hasn't come out, it will eventually come out. But if we get to that certain number, we have to stop for safety reasons.
And sometimes if there's just a lot of raw denuded surfaces, it's kind of hard to get the idea of kind of what the cavity is really going to look like when all that pops open and heals up. And so sometimes if you give somebody a month or two for that to kind of heal, then you have a better sense of kind of the shape of the cavity and what you really need to work on, or if there's areas you need to open up a little bit more if they're completely stuck together.
Do you guys do anything special after the procedure, like during the healing process, when you've got particularly a patient with Asherman's? Like, you don't need to do very much after a normal hysteroscopy most of the time, but do you guys do anything special after? Some people do, some people don't. I'm just curious.
I use estrogen.
Absolutely.
I use lots of estrogen. So I usually try to cycle people like 3 weeks of estrogen, similar to kind of what we would do for getting ready for a frozen embryo transfer. Do that. And then I give them progesterone to help them shed that estrogen. And then I help them build up that lining again and shed it again. And that's my normal thing. Early in my career, I sometimes used balloons. I'm not a big fan of balloons and I really don't use them anymore. And the data is mixed on, it's one of those people, some people are believers, some people aren't. So
I'm on the opposite end of the spectrum. I always use a balloon and I use it for 1 to 2 weeks. Some of my partners even use it longer. We keep the patient on doxycycline, and really the principle behind that is mechanical dilatation. So you keep the two sidewalls separated. I've had really great results. And like Susan said, it's all in your experience, but I've had great results with doing that. I've almost had no one that had additional scar tissue or that, re-scarred again. I usually put patients on about 2 milligrams of estrase continuously, probably from 4 to 6 weeks. Once it looks like their lining has built up, then I'll withdraw them with prometrium. And then usually I'll do a saline sonogram again to kind of see where we're at and what we need to do. And so kind of like what Susan was saying with the estrogen, it's kind of, I use this analogy in this patient I saw this week. Her husband pulled out this picture that made me laugh. So I use the analogy that when somebody has Asherman's, it's kind of like if you plant grass seeds in the middle of the summer in like Las Vegas or, New Braunfels, Texas, you plant it, you don't water it. It's like you see nothing but cracked earth there. And so when you give them estrogen's like miracle grow for your lawn. It kind of helps the grass grow, helps your endometrium kind of refurbish and develop. And so I always use that analogy. I saw a patient in the office this week and I said something about that. And the husband goes, "You use that analogy a lot, don't you, with this kind of situation?" And I said, "Yeah." And he goes, "Well, let me show you he goes, "I thought about you because I was growing grass this summer." So he showed me his before and after picture of growing the grass. So I had to laugh. I like the analogy because people get a good visual of kind of what's going on with estrogen and what it does. But generally, I think if you do that, I also a lot of times will start patients on aspirin and also some vitamin E. We don't really recommend that you take it when you're trying to get pregnant, but vitamin E may, and this is kind of one of those voodoo things. I don't have a lot of great data on that, but it may help vasodilate the spiral arterioles that go to the endometrium and may help with blood flow to the endometrium. So all in all, when I've had people with Asherman's, most of the patients have done pretty well over the years. So that's kind of what I do.
I'm probably somewhere in between. I will frequently use balloons. In general, I like them. But I'll do it for a much shorter time period, like the 5 days or so. And then I will very frequently use the estrogen progesterone as well to just kind of, water the lawn, give it a little miracle grow and see how it works. Okay. So once you've done that hysteroscopy and you've taken your ultrasonographer in and you see everything, how quickly afterwards, like let's say you do however many procedures it takes. You've done 2 procedures, 5 procedures. I think the most I've ever seen is somewhere around 6 or 7. Wow. You've done all of that. And you think leaving the OR, okay, I think I got it. What do you tell your patient next? What kind of follow-up do you do? And when do you tell them it's okay to start trying to get pregnant?
I think that's really dependent on how much Asherman's you have and how much scar you have and how well their endometrium responds and how much normal endometrium you have. I usually see them back every couple of months, 2 or 3 months, because, they start to get antsy and they're like, well, what's going on? What's my lining doing? And really the only way is to look with ultrasound. So I really kind of use more visits with ultrasound monitoring just to get a sense for what's happening with their endometrium. Certainly they can start trying to get pregnant when they're lining. If you're lucky and you get an endometrium of 5 or 6, you're probably doing really well with somebody that had really bad Asherman. So at that point, I'd probably say, go ahead and start trying to get pregnant. But for some patients, you can't get it really that thick. And I think once they start bleeding on their own, like if they're an ovulatory patient, once they start having periods on their own, even if it's not a real heavy period, that always encourages me that there's something going on in there, that the endometrium's growing back.
I would probably recommend, from your last procedure, probably at least 3 months healing.
Yeah.
Is a good marker. I mean, it's probably based on more data having to do with things like fibroids and things like that. But we know that after 3 months, your lining is probably going to be where your lining is going to be at that point, and it's probably the safest it's going to be for you to try to conceive.
I will occasionally do mock cycles where, I let them heal for a month or two and then give some estrogen and do a mid-cycle ultrasound just to see where we're sitting. We'll try one without any meds and then try it with, and just kind of see how things are going. When you guys are looking at linings afterwards, like let's say this is a patient where she's got to do fertility treatment for whatever other reason. So you're doing your IUI, you're doing your IVF with an FET, whatever it may be. How do you approach linings in that patient? Like, what are you normally looking for on just your average patient? And how does that differ in an Asherman situation?
I think we're all hoping to have that trilaminar stripe that I mentioned earlier. I think for somebody with Asherman's, we're way more forgiving when we're looking at the actual width of the endometrium. I mean, I feel warm and fuzzy if I have ideally an endometrium of 8. I'm okay moving on with an endometrium of 7 in a quote normal situation. Whereas in this type of situation, I think the biggest thing is watching for what I call the delta. So where did we start and where did we end up? If we started out at 2 millimeters and we're at 5 millimeters, I'm pretty darn happy, because that's probably way more important. And realistically, I know we cling on to these numbers, and I've mentioned this before, but the data really doesn't suggest that optimal thickness that we all feel warm and fuzzy about, that it actually has any scientific background as to having implications for success. So especially for those Asherman's patients, if you can get some sort of change, I think that's what you're aiming for, is change, not an end result other than the end result being pregnancy.
The other thing I try and do too is I'll check their estrogen levels, because I want to see how far I can push them. Because, if you're giving them estrogen and their estrogen levels 2000, you probably need to back off on the estrogen. It's the end organ that's just not responding to the estrogen. And so giving them more is not going to be necessarily good for them. So I do like to get some sense for how much estrogen I can give them to give them, an optimal benefit from the growth potential, but also don't want to tank them up with too much estrogen, for a long period of time when they're just not, their body just doesn't have the ability to respond to it.
Mm-hmm. And sometimes when we do those kind of test cycles, it'll expose where it works and where it doesn't. So for example, I've definitely had patients where we give them the estrogen, they go through their cycle and their lining looks reasonable, but there's a big black hole in there. So there is an area where you can tell that part of the lining didn't grow back.
It's a big hit. Yeah.
And so you can't control that a whole lot during a timed intercourse or IUI cycle. But if you're doing an embryo transfer, a lot of times we'll try and target like, okay, if I know this midsection is not great, I'm going to go in maybe just a hair further than I otherwise would and trying to make that embryo, be floating around the part that's the thickest and warmest, fuzziest, cushiest place for it to land. You can't always do that, but particularly if you can see where there's deficits, you can try and aim to that. And then what if it just flat out doesn't work? Like you can open up the cavity or you can't get any kind of lining. You've done a bunch of transfers. Where do you go with that?
Gestational carrier is probably the best option for patients at that point, just having someone else carry the pregnancy using the female partner's sperm and the female partner's egg and the male partner's sperm and create an embryo that another person would carry.
Yeah. All right. Anything else, any gems or pearls about Asherman's we haven't talked about?
You got it.
I think we did a pretty good job on this one.
Score. Yes. I'll take it. Okay. So to our audience, thank you so much for listening. Be sure to tune in next week for more. Please subscribe. Please leave us a review on Apple Podcasts. Please hop on social media, leave us a like and leave us a follow and say hello and tell us a funny joke and all the things.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions are answered on the podcast anonymously for the Ask the Doc segment, so don't hold back. We also love episode ideas, so let us know what you want to hear.
And as always, this podcast is intended for entertainment. It's not a substitute for medical advice from your own physician. All right, we'll talk with you soon.
Bye.
Bye.